from Apollo Health City, Hyderabad, and by Dr. PC Rath and Dr. Manoj Agarwal. And I would like to welcome chairpersons of the session, Dr. M. Srinivas Rao, Dr. Sunil Kapoor, Dr. Shivakumar, Dr. Sudhir Koganti, and the other panelists, Dr. G. Suryaprakash, Dr. Nirmal Kumar, Dr. TNC Padmanabhan, Dr. Bharati, Dr. BRJ Kannan.
Hello.
Sir,
Hello.
we are able to hear you, sir.
Okay, thank you very much. Good evening to all of you. Thank you, Dr. Srinivas Kumar, for arranging very exciting meeting, TCT Southeast Asia, in this difficult time, and with the innovative idea of organizing this in PVR theaters. This is very truly innovative, and congratulations, I congratulate Dr. Srinivas Kumar. And for this case, I have with me Manoj and Dr. Basra Kiran, and the case will be presented by Dr. Rupas, and he is the fellow interventional cardio FNB first year. Dr. Pradeep, a junior consultant, is there. A technician, Srinivas, and sister is there. We have kept a very interesting case, very complex case, multivessel angioplasty for you. I'll ask Dr. Rupas to present the case.
Yeah, our patient is a 72-year-old gentleman who had a known hypothyroidism for the last 15 years. In 2017, he presented to us with ST-elevated MI anterior wall, and he underwent primary angioplasty to mid-LAD using an 2.5 into 18 millimeter Science Alpine stent. During discharge, he has moderate LV systolic dysfunction, which progressively improved and it became normal. He was asymptomatic for the last 3 years. Now, for the last 1 month, he has developed typical chest pain, which was intermittent. He also developed breathlessness, which was NOHA class 2. When he presented to us, ECG revealed a normal sinus rhythm with normal axis with poor progression of R wave. Echo doesn't reveal any regional wall motion abnormality. There was good LV systolic function. 3 days back, he underwent coronary angiogram. The coronary angiogram revealed the pattern 3 ISR of the mid-LAD stent, and there is a proximal 70% LCX stenosis, and OM osteoproximal there is a 70% disease. The RCA showed osteoproximal 70 to 80% stenosis, mid 70% stenosis, and the crux is deceased with the PDA showing a significant disease of about 70 to 80%. So he was given the option of CABG in view of his Syndex score being 32 and Syndex 2 being 9.3% mortality over the 4 years for CABG versus 15.1% for PCI. But he denied surgery. That's why here we have proceeded with the option of multivessel PCI.
Can you show the film, please? Yeah. This is the right. This is the right you are showing. Yes. Okay. So this is a very critical ostial block of the right. Mid part there is 70 to 80% block, and distal PDA is totally occluded, almost 99%. Just So this is we dilated with balloon 2.5 2 millimeter balloon initially. Opened that PDA, and they went ahead and first stented the PDA. Go ahead, please. Then we, that is the, that PDA we stented, and then this is 2.25 by 15. Then we did the intravascular ultrasound for the ostial and mid lesion, that we can show it to you. This we used a Philips SD catheter, and show the intravascular ultrasound. Can you see the ultrasound? Can you focus? This is the, can you see it now? Yeah, from distal we are coming to the proximal. Just show the mid part. Yeah, mid part there is a calcified, but around 60 degree only, not much of calcium. Significant block was there, and then come to the proximal. Size of the vessel in mid part was around 2.75, to 8 and come to the proximal part. Ostium on the right was around 3.2. There was mild speckle of calcium, not much calcium. So we decided to stent the middle part first with using a 2.75 by 12 stent, and proximally by using a 3 in 15 stent. Okay, that is the result. Then we check the intravascular ultrasound again and show the intravascular ultrasound again. Show the proximal part. Yeah. Just show the proximal part. Anyway, proximal part, there was a stent malapposition, and that was very clear in the intravascular ultrasound. I hope you can see it now. And yeah, you can see that malapposition there. So we decided to balloon it with 3.5 balloon and dilated it to 3.5, fixed the proximal part of the stent, and that was the result. Just show the angio last. That was the end. So that was the end result of the RCA. Then patient became very, very unstable. He had pain, and we didn't know what to, because the right RCA result was very good. Then we changed over to left to the critical block in the circumflex, and we immediately opened with balloon, and after that the pain subsided. So we put a 2.75 by 15 stent, giant stent, and also we did a OCT there. There is a malapposition again. So the OCT.
I think this is another important point, sir, which you mentioned. We keep concentrating only on the vessel which you did and think about something is wrong there. And you could have ischemia in the other vessels too in a multi-vessel PCI. That's
it was, he was persistently having pain after RCA angioplasty, which was very good. So we thought probably it could be because of the LAD or L6, because we knew it was both the lesions were very critical, especially L6. So that is the, can you see the OCT? Just show the OCT, just shows the malapposition part. Yeah, here. Yeah. Yeah. We also checked the OM vessel. That was significant block, so we decided to put one more stent there. But this OCT showed that, just show the malapposition part. Just, yeah. This area, yeah. This is, you can see that area is under expanded. What is the area there? 3.2. Minimal 3.38. So we decided to use a 2.3 balloon, 312 balloon, and expanded it further. And we also used one more stent in the OM. And after that, that is the result. And we have the OCT now. We can. This is the. So 2.515 stent distally in the OM, proximally 2.75 15, both giant stent, and this is the result. We'll check the final result now. Check the.
Rath sir, we are fortunate to have Dr. Patrick sir has also joined us here, and welcome sir.
Welcome.
Welcome my other friend Dr. Sharmila and other colleagues for the next session. We are running slightly behind the schedule, sir. We request you to bear with us. We'll start it in about 10-15 minutes. Any comments, Dr. Saris? Though you have joined now, we are discussing a multi-vessel PCI. Initially, sir showed right coronary. Now we're tackling the left circumflex. Go ahead, sir.
Okay. Come, Manoj. Just where?
Yeah. Yeah, I was looking at the OCT, but I think the decision to pause dilate is a very good decision.
Yeah. Put it occlude nicely. No, little more.
I think for sake of others, sir has used IVUS in the right coronary artery because osteal was an issue. Still, I think in osteal critical stenosis, we tend to use IVUS more. And because of live case, the patient gets the luxury of using both imaging modalities. And obviously, this is a critical disease where the osteum is not involved, where stent expansion and endothelialization needs to be seen. I think that's where OCT scores showing better pictures. That's how on the left side he has taken the OCT. They're acquiring pictures. You post dilated, sir, again after this?
Yeah, we post dilated. This is the final result. We'll check it if the malapposition is persist or the stent is well apposed. We'll see it now. The right, it was osteal. Osteal also lesion, you can use OCT. There's a technique you just inject.
Guideliner under telescope catheters are being described, but still I think many people prefer seeing osteal.
Wait.
The present OCT catheter has improved compared to what it was before. Previously, to load it also was a challenge. Now there is a definite demarcation done with the lens catheter as well as the distal tip, and imaging is much comparatively much easier with OCT. But for some calcific lesions where it tends to get stuck, but by and large, acquisition of images have improved with OCT compared to what it was before. The more advanced catheter, I think, is not available yet, but even the present generation one is good compared to what it was before. In the live cases, it used to be challenged to thread the OCT catheter itself before. Still, there is some gap there, sir.
Go ahead. This is the where it proximally in the proximal part. Okay, so the whole. Can you see this malapposition in proximal part of the stent? Okay, we dilated with 312. Still, it is there. So the OM is well opposed, I think. Yeah, OM is well opposed. Main circumflex, so the proximal part of the male, proximal stent, that proximal part, yeah, that is the place, I think. You need a 3 with a 3.25.
I think other important point which you need to see is the edges, whether there's no edge dissections, especially.
Yeah, just show the edge dissection, show the edge. There is no edge dissection, so the proximal part.
Just for sake of everybody.
Yeah, just show the proximal part because that's a very important thing to, when you are doing imaging, most important thing is to see there is no complications. Edge dissection is very important. And there was a thrombus also in circumflex lesion that was.
Distally, it's all right. So only proximal
there are some thrombus because unstable lesion. He was having recurrent pain for last few days, and I think you give us a 3 millimeter balloon, short balloon. 3.8 or 3.8 you can take. Give it.
Did we measure the size on OCT, sir? The vessel size?
It was OCT size of the vessel, just check it. We measured last time, but recheck it again.
Yeah, but grossly malopposed studs seen all across. I think it needs better dilatation.
Give it. You're giving, no?
Yes, sir.
Give it.
Dr. Patrick, how much malopposition, how much gap you're okay leaving it, and people say various cutoffs?
Yeah, I mean, in the past we measured that and we found a value of 275 micron could be eventually be accepted because Mother Nature will fill the gap between the vessel wall and
Go
the
back.
struts.
Go.
But I never recommended to let a malapposition. I think that today with these technology that we have pioneered about 10 years ago, you can really be sure that at the end of the procedure, all the struts could be and has to be opposed. I mean, I think there is not a threshold that you should accept today. I think that what is coming now is at least two companies are working very hard in Canada and Japan, Terumo. You will have the first very nice hybrid catheters, which is doing the OCT and the IVUS simultaneously. So you will have the best of the both
Give the stand
technology.
boost.
Yeah.
The French of the catheter would be increased or the same?
No, sorry.
When the IVUS and OCT are there in one catheter itself, the catheter French thickness could increase?
No. They succeed to maintain the dimension of what is a normal IVUS catheter and a normal OCT catheter. So I think that that's going to come commercially available in 2022, 2023. And I think it will be great
The
because
proximally, did you miss out? Yeah, do it.
take the
How
issue
much you
of
went?
the ostium of the right. I mean, you don't have to go from OCT to IVUS. You get both, yeah.
Mm-hmm.
Go. Not the prox. Go just inside, yeah. Yeah. Okay, we went up to 18. Hopefully it will expand. Let's see. No, we'll take a run and finish it up. Looks better angiographically, but we'll do a OCT again.
Yeah, angiographically it looks perfect.
We'll check with OCT now that we have decided to do it OCT guidance. I think we should end with the OCT result. And
So in many trial now for three-vessel disease, you see the use of OCT, but sometimes we have to temper the enthusiasm of the operator because, you know, some of these three-vessel disease do not have a perfect kidney function. So you have to be sure that when you do your OCT is really to appreciate the last dilatation. Otherwise, it could be detrimental for the patient in terms of kidney
yeah,
function.
mostly instead of to do it the optimal, at the end of the procedure, do a OCT to see that the stent apposition is perfect or not, is there any complaint. I think that way you can minimize the contrast.
Yeah, other policy we adopt, sir, is just don't take immediate contrast injection because anyway you'll be taking with OCT. So again, you can avoid one more contrast prior to the OCT catheter and just put an OCT and then acquire both OCT as well as you get a contrast picture with that. So we tend to sometimes save some contrast this way also.
This patient's kidney function is absolutely normal. Creatinine is 0.9. So we are liberal in using contrast in this case. So, but
Sir, what is the further plan? Now you do image with OCT and check this all right. Then what is
go
the plan?
for the LAD.
Yeah.
LAD has a very critical block, instant restenosis, long lesion, and that will dilate and stent, and then with image guidance we'll do that. We gave an option because we had to use multiple stents and triple vessel disease. We gave the option for surgery, but he was not willing. He told, no, will not. I will prefer to have angioplasty again.
When he comes to Rath, he doesn't want surgery anyway.
No,
It comes
that
like
is
prepared.
not the issue.
No, generally patients are referred and they come to you
Yeah,
to
that's
avoid
it.
surgery.
But I gave them the option to go to surgery.
Yeah.
This case, especially in this case, because he had multiple blocks everywhere.
Sir, I think once you image this, if you permit us, we'll go for 1 or 2 lectures and come back.
Yes,
once
we'll do that. We'll just image this one and
Yeah,
then
this is okay. We'll give
yeah,
you the
then we go
surgery.
for the LAD and show you the result end.
Yeah.
Okay, if you want, you can go. We'll finish the imaging and show it to you also. Now,
Yeah, LCX we'll see and then we'll leave you to work in peace. Then we'll go with lectures and come back after everything is
just
done.
see. Okay, just. So I think we have to take one more catheter here. The catheter is OCT catheter is not going. So now just it's bending there. Just show me, give me. Just.
Sometimes it gets kinked, I think.
Yeah, we have.
Then we'll break here, sir. Then we will come back to you once the case is
Just,
done.
yeah, I think you can, we have to use one more catheter and you can go and we'll try to show it to in the, after you come back. In the meantime,
sir.
we'll do
Thank
the LAD
you.
also. Thank you very much.
Yeah, thank you. You have already shown great RCA vessel, how it is tackled, and LCX OM to tackle, and then further in LAD diagonal will be tackled. Dr. Rath, we are able to see you.
Srinivas, I left you with a unexpanded circumflex stent. We took a 2.75 NC balloon and dilated that. You see the picture there. Then we did the OCT, and can you show the picture, OCT picture? Yeah, that is the OCT picture. Can you see that area which was not apposed properly, that has been apposed now? You can see the stent is well apposed throughout. And after that, we moved to the LAD. LAD was an instant restenosis, long lesion, very diffuse disease, and we first dilated with a 1.5 millimeter balloon, and so the LAD. And then that was the result. See the long lesion. So we took a 2.528 stent, delivered distally. Subsequently, one more 2.75 28 stent, and now that is the result. And after that, we did the OCT. There was in the middle of the stent, there was an area where it was the stent had not expanded near the second two stent junction. It had not expanded well. Can you show that? So again took a 3 millimeter balloon and dilated that part. In the end, just show the, and that is the result. So that is the result. And yeah, that is the result. You see the circumflex and OM lesion that was well stented, very good flow. So the LAD, that is the LAD. So he had critical block, 3 places in RCA, 2 places in circumflex and long lesion in LAD, which we stented. We used totally 7 stents, thanks to Abbott's. They gave it, and we used imaging by Abbott's and OCT and by Philips intravascular ultrasound. And the result looked to multivessel angioplasty with multiple stents, but the end result looked to very satisfactory. We had to use between these, in between, alternately between OCT and in intravascular ultrasound because of 2 reasons. One is osteal lesion, and second thing is we didn't want to use so much contrast because ejection fraction was around 45%. So in the end, we finished with this result. Thank you very much.
Thank you, sir, for a great demonstration.
Wonderful work of Dr. Rath. I mean, I think that's a beautiful demonstration of the capabilities of doing this micromanometric work. I mean, it's micrometric. I mean, and I'm sure that that kind of work is competing with the best of the surgeon can do. I'm convinced about that, yeah.
Namaste. I am Dr. A. Srinivas Kumar, Senior Consultant Cardiologist, Director Cardiology and Clinical Research, Apollo Hospitals, Hyderabad. This video brings best wishes to you from FACS Foundation and TCT India South Asia 2021. We are in the live case learning series. This video brings to you the interesting facts and learning points about a multi-vessel PCI done effectively by usage of image guidance by Dr. PC Rath and Dr. Manoj Agarwal from Apollo Hospitals, Hyderabad. What we need to understand is what is the patient presentation and what is the culprit vessel, and then that needs to be tackled first. And also, what is the important vessel which is supplying to the most of the area of myocardium, also to be kept in mind. And depending upon the anatomy of lesions, whether it is the proximal, mid or distal, and also the extent of disease from normal to normal, all these calculations we keep in mind. But finally, what we need to practice in multivessel PCI is to aim for a complete revascularization. Here, this patient presented now, he had an earlier history of PCI to LED with some instant restenosis of mid-LED stent. Now he is presented with inferior wall ECG changes, and then when the angiogram was done, he had a very critical osteal RCA disease, mid and distal RCA disease. He also has disease in LCX and OM and proximal and mid-LED disease. But out of the three, the culprit vessel was thought to be RCA, and that's how it was planned to do RCA PCA first, as the ostium of the RCA was involved after the initial predilatations with the smaller balloons. Then intravascular ultrasound imaging was used, and that's how the size of appropriate size of stents for distal mid RCA and the proximal RCA was taken. As the osteal RCA involvement was there, intravascular ultrasound was preferred over OCT, though there are some techniques described for OCT guidance even in osteal RCA disease. But by and large, IVUS is preferable over OCT for osteal RCA. Initially, after the stent implantation was done with 3 mm stent, there was some malapposition in the osteal RCA in the IVUS imaging, and that was effectively post-dilated and opposed by a bigger sized balloon dilatation later. After the final inflation in the osteal RCA, patient did develop some chest pain and hemodynamic instability. That is again to caution all of us that we need to also keep the lesions in other vessels which are not tackled till then. And the LCX, which had a critical disease, had a development of little thrombus, and that's how the patient started having pain again. The patient was immediately taken for the left side vessel PCIs also, and LCX and OMs were wired. And then after initial predilatation and assessment with the OCT, the vessel size was calculated, and the distally the 2.5 vessels were taken, the approximately 2.75 stent, again which was post-dilated with a bigger sized 3 mm balloon, depending upon the malapposition parameters which were checked. This case was moderated by none other than Patrick Serras, also, who was instrumental in development of the OCT technology. And then when opinion was asked about him regarding what is the acceptable malapposition limits in today's era, he said a decade back probably we used 275 microns as probably acceptable limit where Mother Nature could fill the gap in between. But he felt in today's era of OPCI and accurate imaging, we should actually try to aim not to have any malapposition if possible by optimal balloon dilatations with a bigger size balloon. And importance of more of under expansion creating more trouble was highlighted rather than minimal malappositions. And minimal of at least we should aim for expansion limits of more than 80%, and maybe in between 10 to 20% under expansion could be acceptable, but we should always aim to get a real 100% expansion in the stents all across compared to proximal and distal aspects. These minute details of expansion and then again malapposition were very clearly highlighted in this live case. And other important aspect which we need to keep in mind, especially at the edges, and again thinner vessels like distal OM, things like that, were also to look carefully for the evidence of dissections, distally especially, and to rule out any significant dissections which would cause trouble was also effectively shown well, where the absence of dissections was clearly demonstrated by OCT imaging. Then finally, they went on to tackle the LED lesions. The mid-LED stented, which narrowed stent, was dilated again, and then distally longer stent was taken because the lesion was longer. Then the proximally again, it was another stent was taken to oppose the lesions well. And finally, OCT guidance showed good opposition and good expansion, and final areas achieved were quite good. And this was effectively again shown after the LED stents. In between, then OCT catheters, sometimes in calcific lesions and tortuosities, there could be some kinking, and that's how the another OCT catheter had to be taken for proper imaging in the later half of the case. So that's how finally, with the availability of technology, both imaging by IVUS and OCT, this patient got the best results comparable to surgery. And Dr. Patrick Rath, finally at the end, congratulated the team, and he said now he became more and more confident that we are doing the right things to patients with such meticulously earned results with OPC and PCI methods of IVUS and OCT guidance. And he said there is a patients who do well like CABG in the long-term follow-up. Dr. Patrick Rath also brought out another interesting fact which is likely to come in 22-23 years, where a catheter, hybrid catheter, which has the capabilities of both OCT and IVUS, is about to be launched, and the companies are working on it in both Japan and UK. And when this catheter comes, he felt that probably distally, where the stents have to be seen, you should see with OCT, and the proximal ostial positions and all could be checked with the intravascular ultrasound. And when inquired whether such catheters would be more thicker, he said that similar French catheters, as of what is available in OCT and IVUS, are also the hybrid catheter also is of same French and could go in the 6 French catheters. And hope we will be able to have that hybrid catheter live demonstrations in coming TCTs. With this, now I hope all of you have enjoyed this live case and learned a lot of things in the multi-vessel PCI and the approach of it, how to tackle it, and how to image the osteums with IVUS, and then probably throughout the extents of stents, avoiding dissections and under expansion malapposition with OCT. Thank you. Yours, Dr. A. Srinivas Kumar.